evening, everyone, and welcome. My name is Isabella Johnson from HPV Cancers Alliance. Thank you so much for joining us for session 3 of the HPV Cancers Alliance Emerging Science webinar series, Survivorship and Support, Intimacy, Healing, and Whole Person Care. Before we begin, I want to take a moment to acknowledge our generous sponsors for their support. Those partnerships make events like this possible and help us continue delivering patient-centered programming. I would also like to express our gratitude to our mission partners for amplifying our work and standing with us in the fight to eliminate HPV-related cancers. So for those of you who may be new to us, HPV Cancers Alliance is a national nonprofit whose mission is to empower individuals with knowledge about the health and lifestyle impact of HPV infection and embolden them to take the necessary action to prevent and treat the virus to eliminate its consequences. Our vision is a world where no one faces HPV cancer diagnosis and where compassionate, evidence-based care is the standard at every stage. The Emerging Science webinar series is just one way that we bring this vision to life. These sessions are dedicated to foster collaboration between researchers, clinicians, and patient advocates to highlight the voices of those leading innovation in care. So now it's my pleasure to introduce our moderator for tonight's discussion, Shazia Emmett. Shazia is the head of site and patient engagement at argenx. She earned a bachelor's in physiology and neurobiology at the University of Maryland and has over 25 years of experience in therapeutic development. Prior to joining argenx, Shazia served as the head of the Patient and Physician Services Division at UBC, a global CRO. During her 17-year tenure, she led successful global patient recruitment, site engagement, and retention programs, particularly in the rare disease space. Additionally, she also worked as a study coordinator at the NIH, where she coordinated intramural clinical trials across various institutes, engaging directly with patients and families across various indications. Early in her career at the NIH, one of the first programs that Shazia worked on involved the clinical development of the HPV vaccine. So passionate about healthcare accessibility and inclusivity, Shazia remains committed to developing solutions that address the diverse needs of the rare disease community. Her advocacy efforts and dedication to enhancing the clinical trial experience continue to drive patient-centric innovation across the clinical development ecosystem. So please join me in welcoming Shazia, who will introduce our panelists, and thank you again for being here.
Great, thank you, Isabella. So today's session, again, the topic is survivorship and support, intimacy, healing, and whole person care. I'm going to start off with introducing our panel. Again, a warm welcome to our panel. Thank you so much for taking the time this evening and joining us. It's very much appreciated. I'm going to start with Dr. Amanda Olson. Dr. Olson is a pelvic health physical therapist, entrepreneur, author, and global educator with a passion for empowering men and women and advancing conversations around pelvic health. She has dedicated her career to breaking stigmas around pelvic health, supporting patients with conditions including cancer, incontinence, pelvic pain, cancer, pelvic organ prolapse, endometriosis, and MRKH, and developing innovative solutions to improve quality of life. Amanda is the president of Intimate Rose, a successful pelvic health device company that includes tools for managing pelvic pain, holds multiple patents, and has authored 3 peer-reviewed journal articles, as well as the book Restoring the Pelvic Floor for Women. She's also the recipient of the Elizabeth Noble Award, the highest honor bestowed in the field of pelvic health. She has collaborated with clinics worldwide, transforming lives through her tools, teaching, and consulting. As an advocate for patients with sensitive issues and medical innovation, Amanda is committed to bridging the gap in pelvic and women's healthcare and bringing education to underserved patient populations. Welcome. Devin Schultes. Devin has served as a manager in the Program and Health Equity Department at the Cancer Support Community for just under 2 years. In her current role, Devin oversees CSE survivorship, young adult and community health worker programming, Prior to joining CSC, she managed several interprofessional collaboration initiatives to improve sexual health education and population health outcomes for young people in North Carolina. Devin received her master's degree in public health with a focus on epidemiology from the University of North Carolina at Charlotte. Welcome, Devin. We're also joined by Lynn Barclay, President and CEO of American Sexual Health Association. In June of 2006, Lynn became the American Sexual Health Association's 10th president and CEO. She also worked to bring this 100-plus-year-old nonprofit from a strict disease paradigm to a more positive sexual health paradigm, challenging and changing many long-held beliefs in the process, and working with experts from around the country, from academia, federal government, researchers, as well as corporate America. She leads ASHA in the development of the framework for sexual health, and she frequently represents the organization with the media, funders, and colleague organizations, and speaking about sexual health across the lifespan. Welcome. We're also joined by Dr. Heather Starmer. Heather is a speech pathologist specializing in research and clinical care of communication and swallowing outcomes in individuals diagnosed with head and neck cancer. She is a clinical professor in the Department of Otolaryngology, Head and Neck Surgery, and Director of Head and Neck Speech and Swallowing Rehabilitation Services at the Stanford Cancer Center. She is board certified specialist in swallowing and swallowing disorders and a fellow of the American Speech Language Hearing Association. She currently serves on the boards of the American Board of Swallowing and Swallowing Disorders and the Head and Neck Cancer Alliance. Thank you for joining us today. So I'm going to start off with questions that are grouped into different categories. We're going to start off with clinical survivorship, recovery after HPV-related cancers. The first question I have for the panel is, for head and neck cancer survivors, especially those with speech or swallowing complications, how can speech and swallowing rehabilitation be leveraged not only for functional recovery, but also as a foundation for restoring confidence, emotional resilience, and intimacy in head and neck cancer survivors?
Well,
Who would like to start?
Probably a good person to start with that. When I think about head and neck cancer survivors and their interest in sort of maintaining intimate relationships, there are three sort of categories of areas where I think that it's really important that we as their care teams think about. So one are issues that sort of revolve around identity. So we can think about big things that we use that are parts of our identity. That would be like our physical appearance and things like our voice and our speech. And so when patients have head and neck cancers, they oftentimes will have changes in both of those, where their physical appearance may change, as well as the sound of their voice, the tone of their voice, their ability to talk. And so both of those things can really contribute to reduction in self-esteem, sense of self that's so important for maintaining sort of intimate relationships. And so certainly as speech therapists, one of the things that we try to do is to normalize their communication status as close to, what their baseline was as possible, and also to help individuals identify areas where maybe they're physiologically not able to restore that normal function, but things that we can do to try to achieve whatever their personal goals are. So there's sort of these issues around identity. And then another one, and I hear this from many of my patients, particularly those who are not in, coupled relationships at diagnosis, is when we think about social interactions, almost everything we do is involving food and drink, right? So when we're going out on dates, when we're getting together with our family, spending time with our friends, everything involves eating and drinking. And so for many of my patients who have difficulty, or many individuals who have difficulty eating after head and neck cancer treatment, that can really be isolating. And so it's another area that really impacts overall quality of life, intimacy, desire to date. I've had young people that I've worked with who said, I don't even really want to consider dating because I don't feel comfortable and confident in going out and doing these things. And so again, swallowing therapy, speech therapy can really help to support their goals, to identify, how do we get their swallow to the best that it can be? And then in cases where it can't be normal, how can we adapt the situation to make them more comfortable in it? So how can they order things strategically at a restaurant or be seated in a strategic way during a family meal or while they're out on a date? So working with them, not just about the physical function, but also about these sort of issues around the environment. And then the last piece, which is sort of the piece that gets more into the intimacy piece, is some of the structural changes that are very common with head and neck cancer survivors, the number one being dry mouth. So the number one thing people are dealing with after head and neck cancer treatment is dry mouth. And we can imagine how that's going to potentially impact them in comfort with kissing and comfort with oral sex. And so teaching people with dry mouth how to manage that, what are some of the tips that might work, what kinds of lubricants may be helpful to make them more comfortable, would be a really important thing as well. And oftentimes managing dry mouth is something that is wrapped into what the speech and swallowing therapist does because it impacts eating. So we often have the opportunity to work through that with people. So I think the lovely thing is that as speech and swallowing therapists, we are able to really assist survivors of head and neck cancer to engage in any number of different intimate activities in terms of building relationships, as well as, more in the sexual health area. So that's what I would contribute. I'd love to hear if anybody else has any thoughts.
Great, thank you. I have another question we can jump to. Survivors of cervical, anal, and other cancers often face pelvic floor dysfunction, pain, and intimacy challenges. How can pelvic rehab, patient education, and peer support work together to address those deeply personal issues? Anyone want to take that question?
I would be happy to answer that one. From a pelvic health therapy standpoint, we're always interested in the patient-centered goals. And commonly, people that have experienced cancer and cancer treatments, including surgery, radiation, and chemotherapy, experience a wide variety of different issues, as you touched on, that might include pelvic pain that affects their ability to have a bowel movement and also that affects their ability to engage in intercourse. They may also have bowel and bladder changes that impact not just their day-to-day life and the parts that make us a human, but also their intimacy as well. So what we do is when we meet them, we spend a lot of time talking to them about their medical history and what their goals are. Penetrative intercourse is not a goal of all women. So we try to find out what their goals are specific to that. Because from a mechanical standpoint, the pelvic floor muscles support all of the organs and they can become very guarded as a byproduct of those treatments and stress. It's an involuntary response to engage the pelvic floor muscles. So we're not just dealing with tissue changes as a result of the radiation or the treatment itself, but we're also dealing with a motor control issue that might be new to them. So we use a wide variety of different tools. A lot of times we have real-time ultrasound available, so we can provide imaging and the patient can see the pelvic floor muscles. We have biofeedback, which uses some sensors and a display that shows them when the pelvic floor muscles are turning on and when they're turning off. We can use that to retrain new motor behaviors. And then we might prescribe tools such as dilators, that are a tool used to gently and progressively improve the mobility of the vagina in people that have a vaginal opening. When they are experiencing stenosis, oftentimes it can be painful, but using the dilators is intended to be just a gentle, slow, day-by-day progression in service of being able to have a pain-free exam or pain-free penetrative intercourse. Likewise, for men, they might have changes around the anus and the pelvic floor as well. And we have anal dilators that are assistive for them to regain motor function of the backside of the pelvic floor. And that can also be used in service of anal intercourse for all genders, if that's a goal for them. And then pelvic wands are a tool that empower patients of all genders and backgrounds to address pelvic tender points, just the same way as you get a knot in your neck or in your back. Those can develop in the pelvic floor muscles. And that wand can be used to gently massage and improve mobility of the pelvic floor muscles to address that pain.
Great. Thank you, Dr. Olson. That's great insight. I do have another question. Many survivors report that sexual side effects are minimized or not discussed at all during oncology follow-up. How can clinicians be supported and trained to initiate these conversations, especially for stigmatized cancers like HPV-related cancers?
I'd love to jump in on this one. We hear from survivors at Cancer Support Community all the time that sexual side effects are still so under-discussed in clinical spaces, in that post-treatment care. And so for HPV-related cancers, the stigma that can accompany a diagnosis, even after treatment ends, can really make having those conversations about sexual side effects in a clinical setting even harder. And so we really encourage clinicians to have the tools and knowledge to be able to bring this up. And so whether that's giving clinicians sample prompts on how to start the conversation in those settings, maybe even formal trainings on inclusive and trauma-informed language, or even just kind of encouraging institutions to come forth with that permission and that messaging that, you know, this matters, these conversations matter. And so we like to stress in our educational pieces for both survivors and the healthcare providers that we serve that overall sexual wellness really is an important indicator of overall and holistic wellness and quality of life for so many people, not just HPV-related cancer survivors in that post-treatment survivorship era. And so survivors really shouldn't have to be the ones to always be pushing for these conversations. It should really be baked into an individual's care from the start of survivorship, before treatment ends, and if possible, even before treatment ever begins.
Let me jump in and just say, of course, yes. What we all know, or most of us know, is that healthcare providers are not trained in school on this subject, like at all. I don't want to say at all, but I've been to several big meetings where we discussed this very subject and what do we do about it. And there are trainings out there. They're not a lot. They're not great. And people's time is so hard to get their attention. And so, but it is, as Devin was just saying, everybody else has said, here's the good news. All of us on this, webinar understand the value of this. If we could just make all healthcare providers understand how really important it is to let people come back to feeling like they have something of a normal life. And so healthcare providers play an enormous role in that. Peer support, families. I mean, there's all kinds of people that play a big role in it. But today we're talking mostly about how the provider team can really make that person feel like they are who they were before the cancer diagnosis, which I think is probably what, above all, everybody's looking to achieve.
Absolutely. Very good point. Thank you. So I'm going to pivot to the next topic here around intimacy, healing, and whole person care. The question I have for the panel is, what does intimacy mean to HPV cancer survivors beyond the physical? How do we create healing space for survivors navigating vulnerability, identity, connection after treatment? Who would like to take that question?
I could start, but I think there's others too that will have opinions on this. But one of the things that I found with my patients is for a lot of people that are already coupled, that is how they connected, perhaps, was through that physical aspect. And perhaps they hadn't yet built up the communication piece or had intimacy in other ways and activities of daily living or just other things that are not the sexual physical things. So some of the ways that I educate them from a physical therapy standpoint is to engage in other exercise or activities where they feel close together. The emphasis doesn't necessarily need to be on genitals, but it might be the cuddling aspect or just the feeling of closeness as they're going through this phase and preparing for hopefully what is the end goal of being able to engage in the way that they want to. But what I've heard from a lot of my patients is that the male patients in couples that are in male-female relationships, they don't yet have the communication skills built up and they don't know how to support their partner and use their words. And that's where I'm so grateful for my colleagues in counseling and therapy and in sexual health that can help to build that better foundation.
Great. Anyone else like to add anything to that?
Yeah, I'd love to talk to add on to Dr. Olson's response there. I do think it's really important just to note that connection doesn't all or intimacy doesn't always need to be physical or intimate to have that kind of closeness to someone else. And sometimes that connection or intimacy that someone may be looking for may even just be that connection with themselves or with their partner or partners, depending on where they are in their own experience. And so I think when it comes to kind of that creating the healing spaces for survivors, it really just means honoring and respecting their want and need to explore intimacy and connection, whether that is there or not in post-treatment survivorship. And so we can really create those healing spaces in places where it feels safe and encouraging to have those conversations.
I would add a little bit, and again, this group is very well educated on this subject, but people come before their diagnosis come from so many different places in life. There's age, there's gender, there's prior trauma, there's all kinds of things that impact how they move forward after a diagnosis. And so the more we can really help them know that we see them and that we are there to help them in any way and really give them the tools for them to be able to get back what it is they need of their life is, I think, probably the most important thing that we could do.
Excellent. Yep.
And I think along the same lines is sort of normalizing that there's no right or wrong way, and
Right.
whatever is important
It's your
for
way.
the person is what's right. Yeah,
Right.
exactly.
Right.
Exactly. Okay, next question I have is, what role can speech language rehabilitation play in helping survivors reconnect with their bodies and identities after treatment, particularly when function and communication have changed?
Yeah, it's a really important question, and I think you guys probably see this in other cancers as well. But very often, for particularly people who've had head and neck surgery, I see very often people have a real fear of touching themselves, and their spouses have a real fear, or their partners have a real fear of touching. Nobody wants to hurt anything, right? The incisions are scary. They're worried they're going to hurt each other, and so particularly in the early recovery phase, there's this real hands-offness that nobody wants to touch anything in the head and neck area of the person who's been treated. And that really gets in the way of just these, simple, intimate things that we do with those that we love and for ourselves and feeling comfortable in our own body. And so one of the things that we often incorporate in a lot of the speech and swallowing therapy treatments that we do are hands-on approaches. So it's getting in there and actually being comfortable with touching the neck and moving the neck, having the caregiver providing massage in that area, things that will bring physical comfort, but also support their sort of recovery of function. So many of our patients have lymphedema, for example, and so lymphedema treatment is very hands-on. It's a very soft and a very gentle approach. And that can actually be really, really facilitating for intimacy between a patient and their loved one. I've had many patients who've said that they actually really look forward to these moments where they're working on lymphedema together because it's a safe touch that both people really enjoy, and they kind of look at it as being sort of a date. So I think where we can incorporate sort of physical touch and again, sort of normalizing physical touch and letting them know it's safe through the therapy can really help to move them in terms of their own self-comfort as well as the comfort of their loved ones.
Excellent. Thank you. Anyone else want to add anything to that? Okay, we can go on to the next question. How do we support partners and caregivers in navigating their own experiences of intimacy and emotional healing while supporting their survivor?
Well, let me jump in. So, when you are the caregiver, the partner, the lover, etc., or all of those, all of the above, very often, you come to the table with fear, maybe different from what the patient is experiencing, but your own fear. And so the more information we can give that person, those people, the better they're going to be able to understand what the patient is going through, because very often the patient cannot articulate what they were told, much less what's happening. And so information is power in basically all aspects of life, but particularly in this. And in permission, as Heather, you were just saying, teaching them how to do consensual, pleasurable touch that's helpful is great because then they're part of the team, if you will, and probably the most important part of the team. So empowering our families and even our children to to not be fearful. I mean, there's so many people that are impacted by these diagnoses, and so if we can just give them information, suggestions in a very empowering way, I think that would be the most helpful thing that we could do.
Great, thank you. Going to now pivot to the topic around equity, advocacy, and the public health lens. So I'll start with the first question. What populations are most often left out of cancer survivorship resources, and how can we center their needs in both support services and research? Anyone want to jump in for that question?
I have some if you want me to. I don't want to jump
Great.
on top of anybody.
Yeah.
I mean, we have a real problem in this country on this subject, and I'll just do the high level as opposed to the deep dive because we could do a whole webinar on this one subject. All of these questions you could do a whole webinar on. I kept thinking, oh man, we need more time. But anyway, so racially and ethnically minoritized communities, right? LGBTQIA communities, right? Huge problem there. Particularly trans folk, right? Highly traumatized, and this is a very difficult time. Survivors with disabilities, we don't often think of them, but that is can be a very complicated. Obviously, low income and uninsured, we think of them often, but that's, incarcerated, right? And adolescents and young adults, I'm sure that we're all reading the news about the rise of cancer in young adults, which is, of course, terrifying. But then there's all the things that we need to do, which is basically we need to be doing better trials. We are not doing a very good job of being inclusive on a number of levels. We know all the reasons, or many of us know many of the reasons, but we do need to be doing a better job getting better representation across all of our communities in research.
Great, thank you. Anyone else want to add anything?
Yeah, I think two other priority populations that come to mind for me are individuals who speak English as a second language. So looking at translating and culturally adapting resources and educational materials for them to specifically meet their needs. And then also geographically, folks who are rural and have that limited geographic access to the types of services that they really need. And I think that when we think about how to really center their specific needs in the services, resources, and also the research that we have going on for these groups, we really need to be thinking about working with them to create, materials for them and for their communities. So really engaging them in, from the very beginning, the development process of these materials and making sure that it's not only medically accurate and helpful, but also culturally responsive, and really resonates with these communities.
Great, that's really great, Devin. I think that transitions nicely to my next question, actually, around how can public health campaigns reframe the HPV conversation to be inclusive of all genders, sexual orientations, and cancer types, while also promoting prevention, healing, and the whole body wellness? Any insight there in the panel? Devin, you can even start if you have anything to add there.
I can jump in. Sorry. Sorry.
No,
I mean, this is what ASHA does. So for 100+ years, we really do the translation of the science, and our whole point is trying to talk to people where they are in a way they can understand, which is really hard, way harder than like human papillomavirus never passes the test. But if we one of the things that when ASHA moved from a disease program, when we were founded in 1914, it was all about sexually transmitted diseases, STIs. And then when we decided to move to sexual health, it was because we could put a more positive frame on the subject. And so by being more positive as opposed to fearful about messaging, it is something people are far more willing to read, take in, and respond to in a way that we're hoping to, that they'll get tested, they'll get screened, they'll get vaccinated, all of those things that we want them to do. And one of the things we do is we try to, like HPV, we don't try to say this is an individual issue. We, of course, don't try to shame them. We, try to teach providers about bias and, et cetera. But if we can frame it as, you have HPV, that just means you're normal, since the vast majority of us all have it at some point in our lives. And of course, our imagery that we use is broadly representative of pretty much everybody that we can figure out. And we test images all the time. So we'll put out a message and we'll test 2 different images and we'll go, oh, interesting. That one worked far better. And so that we do all of that. The other is that we talk about healing and, basically whole body wellness. So if we can the message can't just be don't get HPV or don't get a shot so you don't get HPV. We have to talk about it. It's going to happen. You're going to get HPV, and what do you do with it? How do you talk to your partner about it? We do a lot. One of the number one things that people come to the ASHA websites for is help with relationships. And that says a lot about where people are and what people need. And remember, we cover the whole range of sexual health topics. There's pretty much nothing we leave off the list, which is a lot of work. But anyway, the number one thing we always talk about, which is the basis of everything, is healthy relationships. And so that's what we try to convey in all of our communications.
That's really great. It seems like there's a lot of social listening to help adapt to what people want to hear and become more educated.
Mm-hmm.
So I really love that. That's great. I'm going to go to the next question. What do you wish, any of you on the panel, public health and survivorship campaigns included about the long-term speech and swallowing impacts of HPV-related cancers And how can we make those experiences more visible? Any perspectives there?
Yeah, I think one of the things is that with head and neck cancer, there's still a really lack of awareness that this is even a thing, and particularly in relation to HPV. And so, when the HPV vaccines first came out, they were targeted towards girls, and it took quite some time before they started to be used for boys. But even still, we know that vaccination rates of boys are still lagging behind those of girls. And I think if people saw what we see in our clinic every day in terms of the repercussions of these HPV, I mean, the good news about HPV-associated head and neck cancer is it's really highly curable. So that's fantastic news. The not so good news is that nobody is left without some sort of symptoms or side effects that impact their quality of life for many, many years. And so I think part of it is increasing awareness of head and neck cancer and HPV and their relationship, increasing the understanding of vaccination for both boys and girls, because if we can eradicate the disease, we don't have to worry about the side effects of the cures. But then I think the other piece is that as a medical community, we need to do better at being really proactive in managing those symptoms. So, we are very proactive in how we approach speech and swallowing, but I can tell you, I treat people who were treated 5 or 10 years ago in other types of institutions where they had no access to those services. So I think we need to understand that it's not just about curing the cancer, but it's about making sure that whatever that patient's priorities are for quality of life are addressed. So that could be speech, it could be swallowing, it could be voice if they're a vocalist, it could be maintaining their physical appearance. That's very important for some people. It could be psychosocial well-being. So anxiety and depression are really, really prevalent in individuals with head and neck cancer. So I think awareness of the disease, the importance of vaccination, and then proactively really trying to prevent these long-term side effects are all things that are really, really critical.
That's great. And it seems like also like just making sure they're connected to the right resources and feel comfortable asking for those too.
Right, right. And organizations like the Head and Neck Cancer Alliance do a wonderful job of making available so much information about survivorship and living well after cancer care. And so making sure patients are aware that there are organizations like that that really can support them from diagnosis throughout survivorship.
Right. Anyone else want to jump in? Okay, I have one more question for the panel. If you were to look ahead, what's one area, could be clinical, educational, or policy related, you believe needs urgent action to improve the lives of HPV cancer survivors? And I'll start with Devin.
Sure, yeah. If I had to pick just one thing to act on, and that is very difficult when we know the kind of landscape here, I think that it's just that conversations about sexual health and intimacy should really be core parts of care and even just treatment too, and not these optional add-ons, as they often are. And so I think that means real formalized training, as Lynn was saying, really expanding upon those and making them robust and helpful for folks. Also seeking and gaining funding to put on these types of things and deliver these resources to survivors and others with HPV-related cancers. And then also just really a shift in how we define recovery. I think that all people impacted by HPV-related cancers and survivors in general really deserve care that honors every single part of their experience, not just the parts that we're most comfortable talking about in clinical spaces and public health practice. So just really, yeah, focusing in on those things.
Great, thank you. Great input. Dr. Olson?
Absolutely. Similarly, including screening for sexual health function for all patients that have experienced cancer, and then having a referral to pelvic health therapy being automatic because of the role we play in bowel and bladder and sexual function as well, to help address the goals that oftentimes feel like the rug's been pulled out because they weren't made aware of them going into the treatment.
Excellent. No, go to Dr. Starmer.
Yeah, I totally agree with everything the other panelists have said. I think another thing that I would add in is I really think we have a mental health crisis in this country, and we have a real lack of mental health professionals who can support patients and survivors and their caregivers in all of the different challenges that they experience from diagnosis through survivorship. And so I really do think that we need to find ways to optimize the mental health support for the entire, team of people that are caring for the individual with cancer, because I think it just affects everything from survival to functional outcomes to quality of life to intimacy. So I think mental health would be an area I think we really need to prioritize.
Excellent. Very good point. And I'll go to Lynn.
I think I don't really have anything helpful to add because they've added such great comments, but I will, because I'm American Sexual Health Association, sex is great. It's important, however you define that. And we need to not only treat the disease, but treat the person. And that ability to have control given back to people may be equally maybe as important as the cure, how the rest of it goes, because if we have a loneliness epidemic, then we don't need to be causing it. We need to be doing the opposite.
Great. Thank you. Well, this concludes our webinar. Again, thank you to our panel for taking time today and participating. I know this insight was very helpful, and it's just great to be part of this to support the HPV Cancers Alliance and the mission to spread knowledge, save lives. Thank you.